This video is brought to you by Straight Goods News, Canada's alternative online news source. Visit straightgoods.ca.
In different areas, and just as saying clearly, the pharmaceutical companies have a very big interest, as do the insurance industry, in maintaining the current pharmacare non-system. But in terms of making the processes of care more efficient, reducing wait times within the system, especially, that really goes to the fact that the processes of care that we've got are antiquated. And so, for example, the referral system to medical specialists hasn't really changed much in 1,000 years, and so that as a result, somebody gave me an example that was even more extreme than one I'd been using, where somebody who'd been waiting to see an orthopedic surgeon, and they saw the orthopedic surgeon, they didn't have an MRI done, so then they were sent away to have an MRI done, but it took more than 6 months to get the MRI, so therefore, by provincial rules, they needed another referral from their family doctor before they could go back to the specialist, but then the MRI was going to be outdated by the time they got back to the specialist, and then they'd have to get another MRI, and so yeah, it'd be catch-22. And when we change the processes of care, and the example I always give is like in Hamilton, where they've integrated the practices of 20 psychiatrists who work on average 1/4 time in the program with 100 family physicians, 80 mental health counselors, most of whom are social workers, and about 100 nurses, and lots of other personnel, and a very large family health team. And that program, which has been in place for over 15 years now, developed by psychiatrist Nick Cates, has got wonderful results, but they've been able to increase the number of patients diagnosed with mental health problems by 11-fold, and we know that mental health problems are greatly underdiagnosed and treated, and it's so way better access. And then you'd think, well, now we've got all these sick people we've diagnosed, we're going to flood the psychiatrists, they won't be able to handle them. But because the people are now getting their care within primary health care, even though they've got 11 times more patients identified, they've actually dropped by 70% referrals to the psychiatry specialty clinic. Now, I'm fed up with talking about this wonderful example for 15 years, particularly in Toronto. You say they're doing something brilliant in Hamilton, they say, oh, wasn't that cute? We didn't even know that they could, deal cards, and they sort of say that's sort of cute what they've done there. But clearly, if they're doing it right there, and in Winnipeg they've replicated that program more or less, then if they're doing it right there, then everyone else is doing it wrong. And we're doing it wrong in all specialties. So all medical specialists should be integrated into primary health care practices. To do that, you have to change the way doctors are paid. You have to get people to do things differently. No human being likes to do anything. They don't like change unless the baby with a dirty diaper, perhaps. So it's very difficult to get people to change. But the problem within healthcare is that providers, and this is true of all providers, but it's especially true of my discipline of physicians, we don't want to change. And so, bank tellers didn't want to change the way they did things 30 years ago, but they had to change. And now, but when physicians don't want to change, they really don't change. So I think you're seeing coded versions of that from the right, from Drummond and other people, as well as on the left, where people are talking about, we don't integrate doctors. I think we just have to be plain that the way we have physicians organized in our system, it will never produce good quality care. That there are only two options. You either have to do what they've done at the Mayo Clinic when Charlie Mayo got fed up in 1923 with his fee-for-service doctors. He put them all on salary. The Cleveland Clinic, all their doctors are on salary. They have one-year contracts. Performance appraisal, they don't meet the performance, they're out. Now, I'm not saying that we should be, treating doctors as badly as some other people are treated by their employers, but I am saying there's no accountability. And if you don't want to be on salary, like in the Mayo Clinic, if it's good enough for the Mayo Clinic, it should be good enough for your average practice. Then the other model is a Kaiser model, where you've got which has been somewhat replicated in Sault Ste. Marie, where you have a disciplined medical group that then enforces discipline within the organization. And you cannot have this sort of loose private practice where doctors just wink at each other and say, I'll do something innovative, you can just keep on doing whatever you're doing that's completely inefficient. So I think that particularly for changing the processes of care to improve efficiency, we are going to have to really start talking. This is the adult conversation that Mr. Dodge isn't talking about. We have to talk about a new arrangement for physicians in the Canadian healthcare system.
Okay, but who's going to take them on?
Well, I think first...
It's political suicide to take on doctors.
I think that, the way it needs to be done is that you're right, governments can't go head-to-head. Governments are completely petrified, sign terrible deals, get nothing for all the money that they give doctors, because they are completely petrified of doctors. So what they need to do is they need to start opening up these policy discussions. Ontario's put hundreds of millions of dollars, at least, into their primary health care reform, and a lot of my friends are practicing in slightly more innovative ways, but the indices are still, the indicators are still awful. In Ontario, we're slightly better than the national average, but in Canada, we're the worst when it comes to using emergency rooms, to not having access to a family physician the same day that we're sick. We're the worst of almost any wealthy country. So I think that what we need to do is governments have to stop going to the bargaining table and defining new primary health care models there, which I think has been Ontario's big mistake. Open up the policy debate so that other people, like me, I'm willing to, will take on physicians and say that if we're going to give more money to physicians, it's going to have to be for clear accountability. But I think that that's the key for a lot of our health policy. The reason why we don't go anywhere is because the real decisions are behind closed doors. So we go to these meetings, Sharon, it doesn't matter. There's no transmission belt between the debates we have in these meetings and then what goes on at the bargaining table when policy is set. So governments have to open that up, and they have to use people, and they have to use patients in the system especially to to counter the influence of providers.
Might be that it's hard to turn a ship around. It might well be that there are all kinds of interests all over the place that are kind of resisting some of the things that some people want to do, and these include people who are in the health system itself. Remember, people who are involved as health care providers, don't necessarily want to work on teams, don't necessarily want to give up some of their scope of practice to somebody else who might do it better, and so on and so on. So there's that kind of thing. The second thing is, it might well be that we haven't had a federal government in a while, at the very least, that wants to introduce any new shared cost programs. They don't even want the existing one. The bare bones Medicare Canada Health Act program. So when you have a government that says, I'll just give you the money, you can do whatever you want with it. We don't care about comparable access to services across this country. We don't care about a patchwork quilt of services outside of Canada Health Act services. I mean, that's an impediment. So we have to lobby for these things. But I would say that some like-minded people have to sit down and actually draft some legislation. And I'm against, by the way, opening the Canada Health Act. I wouldn't dare do it. I think whatever's in there would be lost in the current circumstances, but I would like to see some companion acts, a home care program that's defined. It might not be everything we want to start, but something to start, a Pharmacare Act, and I would be willing to sit down with some people and start drawing it up. But think also about the interests, the people who are in the health system and outside, who don't want to do anything about it.
I'd like to quote the FIKE report from the Royal Commission in Saskatchewan in 2001, which said very wonderfully in their executive summary, good quality care is almost always cheaper than poor quality care. And that's something I think particularly for many of us in this room that we've really got to address. I go back to the 60s, people like me wanted Medicare because it was public finance, it was equitable, it was more efficient. But also, we didn't want the old healthcare system. Some of us were involved in setting up free clinics and those, because we thought that the old system, go see a doctor and tremble and then get the received wisdom. That model sucked big time, and it wasn't patient friendly. And I think that for many of us on the left, we've lost that cultural critique of healthcare, and that's what we need to bring back. And that cultural critique brings us to quality, because I think in the Pharmacare battle, again, I completely agree with everything Mike Andre is saying. But what? One of the things we're really leaving out here is there's just crummy quality prescribing, and your family doctor is responsible for the OxyContin epidemic that we've got. Why do we have 20% of older women in this country taking long-term Valium-like drugs? Why are 1/5 of the broken hips in Quebec due to these drugs? So that clearly we need to, I want Pharmacare, I want first dollar Pharmacare, but we can't have it administered through a system where you've got family doctors who know very little about drugs. There are $20,000 per doctor spent by the drug companies in propagandizing their products to them. So we can only have an affordable pharmacare system if every family doctor has to work with social workers and physiotherapists and people who can provide non-drug therapies. And when they work with pharmacists, and just, like in the Quebec CLSCs, when a mother phones in and she's concerned about how her kid is doing at school, she doesn't see a doctor. She sees a social worker first, and then if she needs to go on from there to a doctor, then that happens, and then you don't have every kid on Ritalin. So I think that I just, strong encouragement for everybody in this room to think like the 60s. We want public coverage, but we want a completely different system, and we need professionals turned on their heads and spun.
The Canadian public are fully behind our system. Our politicians are fully behind our system. This room is fully behind our system. So that's what gives me hope. But it's the day-to-day slogging through the issues that we need now to say we're finally going to start to address those. And we're prepared to hold our political leaders who own the system on our behalf, shall we say, to account for that. At the same time, they will be prepared to take the politics out of healthcare, and then we can have a informed, evidence-based discussion to really get the right solutions on the table and to move forward.
And I'm counting on you to give us a shining light home with a couple of last little points of shining light on Medicare.
An optimist is just somebody who doesn't know all the facts yet.
There you go.
But I think that there are several things that keep me going. One, I'm going to the largest healthcare quality meeting in the world on Saturday in the United States, the Institute for Healthcare Improvement Annual National Forum event, and there are way more Canadians going to that event than ever before. And despite notwithstanding what I've been saying about processes stuck in the Middle Ages and all that kind of stuff, that there's absolutely no question that doctors, nurses, other health providers are much more aware of these kinds of issues we've been talking about. And I really do feel from my better days that we're on the cusp of something great. And then secondly, that I go around this country a lot and I talk to lots of people, many of whom who don't share my core values. And I find that Canadian conservatives, when you sort of strip away the mythology that's thrown at them every day, are actually very strong supporters of Medicare, because Medicare is this wonderful, actually, amalgam of, Tommy Douglas's social justice and Justice Emmett Hall's, it just makes sense to have it as a single payer because it's going to be a whole lot cheaper. So it's wonderful Canadian pragmatism, wonderful values underneath our Medicare system, and I find that those values are still there, although they may be disguised by some current conservative governments. And then finally, I think that the other thing that makes me feel optimistic is that, of course, children of the 60s, we all felt that the world was going to get better and better, and more equity. It was just going to be, more human rights. It was going to be better all the time. It didn't work out that way. But on the other hand, there, what you miss in the swings, you pick up in the roundabouts. And I do feel that and again, maybe just because I don't know all the facts yet, that with the Occupy movements that we've seen, and with the responses, even central bankers like Mark Carney, that people talking about too much inequity, that's kind of right. So I do kind of feel as well that we're hopefully at the end of a long wave of Friedmanism, Reaganism, whateverism, and that we're going to be going back to the values of equity and community that Roy Romano was talking about. So if that's not unrealistic, there you go.